afternoon to everybody who is on today. I am Bill Frist, and I'm delighted to be opening up this very exciting webinar for the National Institute for Healthcare Management. So let's get started. Palliative care is one of the fastest growing specialties in American medicine today. And the most important factor about all this growth is it is driven by need. Our aging population, combined with the financial shift in medicine from the traditional fee-for-service to more value-based care, has now opened the window for new models that can appropriately care for the chronically ill in a cost-effective yet high-quality way. The current reality is that about 5% of the U.S. population spends 50% of the healthcare dollars. You can see that here on this slide. The people on the horizontal axis, between 95 and 100%, those in the red box, are accounting for over 50% of all of that healthcare spending. And what's interesting is that the people making up this 5% are largely the chronically ill or the actively dying. 5% of Medicare beneficiaries, that's about 1 out of 20, die each year, and their end-of-life care accounts for over a quarter, or 27%, of Medicare spending. Whereas 95% of all Medicare beneficiaries will spend, on average, $4,400 in a year. 5%, or 1 out of 20, at the end of their lives will spend more than $26,000 in that same year. And why does it cost so much? Sadly, in the last 30 years, end-of-life care in this country has been a highway to the intensive care unit and the costly dying or death in the hospital. This whole model that has evolved over the last 30 years is fraught with problems, the least of which is what I started with, and that's the cost, although it's big, and the most important being the the destructive impact it has on the patient and that patient's family and loved ones in terms of quality of that overall end-of-life experience. So what do we do about it? From a cost perspective, targeting this 5% is a potential place for major cost savings, but even more than that, it is the right thing to do. People don't die today the way they'd like to die, and we all deserve a good death. And it's the palliative care model that has evolved over the last 15 years or so that specifically offers that. But targeting this 5% requires identification of people with chronic illness who are approaching the terminal cycle of hospitalizations that will eventually lead to their death, and offering them instead a different, more appropriate, and more satisfying model of care. And we actually can do this, for example, by using modern claims-based algorithms made possible today by sophisticated and modern use of big data, and computers, by physician team partnerships, by telephonic and in-person assessments, among many other models. So there's a huge need for palliative care. But what does palliative care really mean? What is palliative care, and why is it the solution? I love this quote by Isaac Asimov. Life is pleasant, death is peaceful. It is the transition that is troublesome. You know, it's so true. But the good news is that Asimov didn't know. He didn't have the advantages of knowing about palliative care. Palliative care makes the transition, using Isaac's words, less troublesome. Palliative care is that optimization of quality of life to relieve the suffering of critically ill, very sick patients at times and their families by focusing on maximizing symptom management to relieve pain and increase comfort. This is done while carefully considering and addressing the emotional and the social and the spiritual needs of the patient, as well as the physical and the family, during the course of illness and after death. What does this really look like? And let's just take an example. Here you meet Alma. She's a 74-year-old woman who is a smoker with advanced chronic obstructive pulmonary disease, type 2 diabetes. She's on insulin, has the initial stages of dementia. Her husband Jack is at home and in relatively good health, but is also 74. Both of her children live out of state and are not involved in her day-to-day care. And unfortunately, Alma has started that terminal readmission cycle in and out of the hospital we see so often, and has been in the hospital 2 times in the last 2 to 3 months for shortness of breath, with the last admission lasting 8 days. Each of those admissions is expensive, is taxing, and they are wearing Alma and her husband out. They're exhausting them. Enter the palliative care model. Instead of putting Alma into a cycle of readmission, bouncing in and out of doctor to doctor and hospital to hospital, we put Alma in the center and bring the resources to her and to her family. And not only does she benefit from things like 24-hour telephonic monitoring, but her outcomes, her experience will improve as well. And that's an evidence-based assertion that we know today. This article from the New England Journal showed increased quality of life scores in patients in a palliative care program. They also showed 58% less depression, 39% less aggressive end-of-life care, with aggressive end-of-life care defined as chemotherapy within 14 days prior to death, and longer median survival times, almost 12 months versus 9 months. And that cost issue that I started with, we've also shown all of this reduces cost. This article from the American Journal of Managed Care presented a randomized controlled study of palliative care model as applied to a patient cohort that largely carried an oncologic diagnosis. The group randomized to palliative care had 30% fewer emergency department visits, 38% fewer hospital admissions, and 2 years more life expectancy. And this all happened at an $18,000 per patient per month lower price tag. And the secret is in moving the locus of care to home. Palliative care seeks to be patient-centered and deliver care where the patient is most comfortable and most familiar and most secure, resulting in better outcomes while at the same time being more cost-effective. This slide shows just that. A palliative model reduces hospital days while increasing home health visits in its place. Now, I want to show you something fascinating to further make this point. The first slide is from the Dartmouth Atlas, well familiar to all of you, and looks at the number of hospice days per region. The dark areas on the slide mean more hospice days. I'll come back to this slide shortly here, but just take a look at it and look where the dark areas are. Now look at this next slide on inpatient dollars spent. This is where inpatient dollars are spent. Again, dark means lots of dollars and light means fewer. These two slides are almost the exact inverse of each other. Let me go back and show you once again these two slides. Let's flick to that next slide. Hospice days used in the last 6 months, and then once again the inpatient spending, the inverse. So having discussed the problem and the solution, let's put all this together and talk about the huge opportunity before us. The 3 models, really 3 major models, if you have to have 3 big buckets out there today addressing it. One would be similar to a Aetna Compassionate Care, who uses a telephonic case management program focused on patients facing a terminal illness to improve the outcomes and decrease hospital admissions. A second example of a different model would be that of Kaiser Permanente, and they actually providing home and hospital and clinically based palliative care to their customers at a capitated price. The third model would be a company like Sutter Health Advanced Illness Management. They connect 24 hospitals and over 5,000 physicians in Northern California to bridge the gap between acute care and end-of-life care for Medicare patients using a more traditional fee-for-service model. Now, all three of these are successful, and an examination of their model reveals several commonalities. First, they all show strong leadership and vision. Secondly, they use sophisticated, modern information technology systems and electronic medical record. Third, they have achieved physician buy-in, absolutely critical, by framing the service as additive to their physicians, not replacing them, not supplanting them. Fourth, they use a capitated or a value-based payment system to reward providers who actually reduce inpatient care. And fifth, they have a patient and family-centered approach, like that graphic that I showed earlier of Alma, smack dab in the middle of that team-based approach. And finally, they're using palliative care physicians, people trained, specifically trained in end-of-life care. The truth is, in a palliative care setting, the goal is improved quality of life, which means better symptom management, reduced episodes of acute illness, and overall better patient well-being. And the only way to achieve this is through a coordinated, seamless medical team model. So, of course, you ask if value-based care in the palliative setting means coordinated care, and the outcomes achieved are clearly cost-saving, why in the world isn't everybody already moving to this model? And the reason is the same. Current reimbursement models simply do not support it. We bill for procedures, not outcomes, and even the shift to paying for outcomes is physician-centered. Chaplains and social workers, which are imperative to overall good, excellent care, especially when you're dealing with physical, mental, emotional, and spiritual health. But they don't, in turn, generate a revenue under the current model, so the current model must be changed. What are the barriers? Specifically, we're facing a host of barriers. Some are regulatory and others are out there in the market. First, on the regulatory side, the Medicare statute, the Social Security Act, has been interpreted to exclude supportive care, like that provided by most members of a palliative care team, because coverage is limited to interventions that improved health only. The actual quotation is, care is covered unless, and these are the exact words, not reasonable and necessary for the diagnosis or treatment of illness or injury or to improve the functioning of a malformed body member. Those are the words out of the Social Security Act. However, the light at the end of the tunnel are that the Medicare readmission penalties of the last couple of years for patients who are readmitted within 30 days for certain conditions, and those conditions are heart failure and heart attack and pneumonia, all of a sudden gives us a new opportunity to reform and to shape reimbursement. Additionally, the Center for Medicare and Medicaid Innovation has established programs that fund cooperative agreements and challenge grants which aim to demonstrate this integration of supportive care with traditional medical services. So there is some progress on the regulatory side, minimal it may seem, but opportunity is there. Let's flip over to the side of the market forces and culture change, and we're also facing barriers there. We need to address these barriers right up front. Not only must government-sponsored insurance change, but private insurance as well. However, changing payment models, as much as it must happen, is disruptive, especially given that healthcare is a whopping 18% of our gross domestic product. Secondly, there's an issue of physician buy-in. Doctors are used to caring for their chronically ill patients in one way, many times the way in which they were trained and the way they're most comfortable with, And this model, this current model, changes all of that, much more of a team-based approach. Physicians have to have some skin in the game, or they simply are going to oppose it because of their more conservative ways as this change comes forward. We want the outcomes palliative care can offer. We know they're there. We know by applying the system of palliative care, we can achieve both the cost effectiveness, but much more important, that experience and outcomes that we know that the patient receives. We want the cost savings that the palliative care can generate, but to do that, the payment model absolutely has to change, which requires proving to payers with data, with our models, that a medical team approach works, and then finding people brave enough to venture in the palliative space when payment is not guaranteed. Private payers are uniquely positioned to make these changes because they are not subject to the same challenges as those government-funded health insurance. But there is also a unique opportunity for new business models entirely to help influence the system and shape the system of the future. In order for private payers to invest in palliative care, though, payers need to have confidence that care will be delivered in a consistent way that is cost-effective, that is scalable, that produces a positive return on investment. And this is one of the reasons I've teamed up with several people to launch Aspire Health. And as you're going to hear shortly, Aspire is recruiting some of the best palliative care physicians in the country to set up independent palliative care physician practices, and the physicians and practices are building home and outpatient-based palliative care programs focused exclusively on partnering with private payers and accountable care organizations. To support these practices, Aspire has built sophisticated patient identification algorithms and an information technology system that allows us to proactively identify the patients who could benefit most from palliative care, and then track the clinical and outcomes data that matter specifically for palliative care patients, and allows us to share these data in an easy, seamless, and reliable way with those patients, primary care physicians, as well as specialists in the health plan. So to tell you more about what we're doing with Aspire, please let me introduce Brad Smith, co-founder and CEO of Aspire Health, and Dr. Andrew Lasher, our Chief Medical Officer. Andrew, why don't you take it from there?